Next we have Sanjeev Srinivas, son and protege of SKR, who has been teaching us in Kerala for a very long time. Now the mantle seems to have been handed over.
Okay, so thank you for that introduction, sir. So I'll be talking about recurrent corneal erosions today. So we've all seen this patient in our OPD at least once. So you see an epithelial defect, you don't know what it is, you see microcysts and you see microcystic edema, you see stromal cells, there's no pattern, you do an OCT if you have one, and the anterior segment OCT shows basically what's an epithelial keloid with hypertrophic epithelium. So we all know this is recurrent corneal erosions. Patient sitting there in front of you screaming pain, 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 and you don't know what cause it is because you ask him what happened and he says, I don't know. I just got up in the morning feeling this way. So RCAS has quite a few etiologies. The first and foremost being a previous abrading injury. Apart from this, if it's bilateral, you must think of epithelial basement membrane disease. You also have to think of corneal dystrophies. Band-shaped keratopathy, Salzmann nodular degeneration can also cause it. It can also occur sometimes due to prior surgeries. For example, if you have your oculoplasty surgeries, your cataract surgeries, your glaucoma surgeries, your second instrument can sometimes brush the cornea, which can lead to this problem later on. Now, the pathophysiology behind it is this. Basically, you have this unit called the hemidesmosome, which actually anchors your stratified epithelium onto the cornea, corneal basement membrane. When you have this injury, these hemidesmosomes get injured. And then what happens then is the cells then start to desquamate because there's no way for them to be held on. As these cells desquamate, they get trapped underneath the basement membrane. And then this forms something like a speed breaker. And then as the cells start to grow to close the defect, they no longer have a smooth surface, so they start to grow onto each other. Now what happens sometimes is as you sleep, the cornea due to hypoxia undergoes nocturnal drying. As it is, this epithelium is loose, and then sometimes during your rapid eye movement sleep, or if you get up in the morning with forceful eyelid movements, the epithelium gets avulsed, and that's when you have the searing pain. Apart from this, you also have an upregulation of matrix metalloproteases 2 and 9 on the surface. Now this is important, especially when we come to the treatment aspect of it. Symptomatology we all know, so I just told you at least 2-3 times. Apart from this, you can also have cysts on the corneal surface. Now sometimes it mimics epithelial edema, so please be careful while looking at it. You can also have fingerprint and map top patterns which typically take up negative staining. Now how do you diagnose? A slit lamp diagnosis is more than sufficient with the fluorescein staining, of course. An ASOCT obviously will help demarcate the exact area of the basement membrane break. And if you have confocal microscopy, you can do it, but that's just more for experimental purposes. Now coming to the management, of course, medical, you have to treat them medically even though you're going to manage them surgically. So acute attacks, you give them preservative-free lubricants to help the surface heal. You give them a bland ointment. You can put them on cyclosporidics. Steroids are plus minus depending upon the inflammation. Bandage contact lens and doxycycline will help in the short term. You have chronic attacks, you can even choose to put in hypertonic saline drops. But the surgical management is basically where it's at. So recurrent corneal erosion sadly ends up being a surgical problem. So this is something that's very, convenient, easy to do. This is anterior stromal puncture. Now if you notice, this is a hockey stick knife, it's blunt. So if you notice when you're peeling the epithelium, it just sort of sloughs off. That's because there is no attachment of the epithelium. You can see it's hypertrophic. It's a lot more thick than the surrounding normal epithelium. So if you just peel it, it will come off in one go. After this, you make sure you freshen the edges, otherwise the healthy epithelium cannot grow over. You can then take a 30 gauge or a bent 26 gauge needle and make punctures like so. Keep the punctures close to each other, otherwise you can have a recurrence between the punctures itself. Now you have to go at least 50 to 75% depth in order to get adequate scarring in these cases. Now after this, you put the patient on a BCL and let the surface heal for about 2 to 3 weeks. No post-operative steroids, and usually you will get a good successful outcome. This on the other hand is a lot better. This is basically a diamond burr. This is the drill that I use. It's got a diamond tipped burr at the end which contains basically industrial diamonds. They're not the diamonds we buy at the jewelry store. Now this is the drill itself, so it's basically speed controlled with a foot switch. It goes up to 50,000 RPM, but for corneal procedures we use somewhere between 4,000 to 8,000 RPM. Now if you don't have access to something like this, you have this which is available on Amazon. It's called the Alger brush. It's only about 7,000 rupees. It's battery operated. It's very easy to purchase. All of you can have it in your OTs. Now the only thing that I'd like to touch upon when we talk about RCE management with the diamond burr is that most of us make the mistake of going and polishing the edge of the defect. that is not where the actual polishing needs to be done. It actually has to be done here. You will actually feel it based on tactile feedback as a speed bump. It's like a lifted edge on the cornea, which you actually have to smoothen down before you can say that you've successfully treated the RCE. If you do not smoothen that part and just keep continuing to scratch at the edge of the defect, you will have a recurrence invariably. So coming to results, if you look at, this is just a quick literature review I did on a train today morning. So if you look at focal ASP, most reports say it's 80% success rate, so you have a 20% chance at recurrence. But of course, you will have scarring. So if it's in the periphery, you can always consider it. But if it's in the central, you ideally choose to avoid it. If you just do an alcohol delamination with an epithelial debridement and then put in a BCL, this is obviously the faster mode of rehabilitation, but there is a very high risk of recurrence because you're not treating the Bowman's irregularity. What I did find was if you did a delamination followed by a debridement and then you do a diamond burr polish and then put in a BCL, the success rates are almost 95%. The only thing is that you will have a bit of stromal haze post-operatively, which has to be managed with steroids, even though there is a BCL in situ and an epithelial defect. Lastly, PTK is we also do PTK, but it's very prohibitively, it's prohibited by the cost and also the fact that it has almost a 25% recurrence rate. So with that, I'll conclude. Thank you all for your time.
Thank you, Dr. Sanjeev, for that excellent.
Just one question, Dr. Sanjay.
Yes.
Can we use the Nd:YAG laser to do the anterior stromal puncture? If so, what are the parameters?
Yeah, they've actually used the Nd:YAG laser for both stromal puncture and to remove the Bowman irregularity, ma'am. But see, the thing is energy titration and the depth. So if you're too deep, you will damage endothelium.
Yeah,
if you're too superficial, it won't work. So the thing is, at this point in time, we do not have the laser that's precise enough for that. Yeah.
Thank you. Thank
Yep.
you so much.
Dr. Sanjeev, one more question. When you use the diamond burr, will it damage more stroma? No.
No, the specialty of the diamond burr is that it will not cut, it will only smoothen. That is the specialty of it. So because it's like I said, it's just diamond dust. So the goal of the diamond burr is to basically flatten the surface. So it will never cut. So you can use it even in your pterygium cases. When you've removed a pterygium and you have these strands sticking out, you can use it. You will never see a defect form. You will only see it smoothen the surface, but it will never cut. Yeah.
Thank you. Thank you so much. Actually, we use in our orbital decompression surgeries. That is why I asked.
Yeah, but you will get a little bit of haze post-operatively because there will be a bit of sterile keratitis that you can manage with a steroid. It will get better.
Thank you so much.
Thank you, ma'am. Yeah.